All right, let's jump right into this explainer and demystify the highly coordinated, sometimes stressful process of undergoing surgery while you're taking buprenorphine, which you probably know better by brand names like Suboxone or Subutex. For a long time, there's been so much confusion, fear, and frankly, conflicting information floating around about this. So today, we're going to bridge that gap by looking straight at the latest clinical guidelines, focusing heavily on what surgeons are looking for and the exact steps you, the patient, need to take.
Right off the bat, this is the most common panic-inducing question patients have. If you're prepping for a procedure, you're probably wondering, is my medication going to mess with the anesthesia? Or will I literally just be in agony? Well, the reassuring answer is yes, you can absolutely undergo anesthesia safely. Organizations like Bicycle Health and the American Society of Regional Anesthesia and Pain Medicine make it clear you can have a totally safe, pain-free surgery as long as there is tight coordination between you, your prescriber, and your surgeon.
To put this into perspective, the stakes here are absolutely massive. We are talking about 2.5 million Americans dealing with opioid use disorder. Buprenorphine is a literal lifesaver for this condition. But here's the crazy part. Statistics actually show that the death rate for these patients peaks in the very first month after their discharge from a hospital. Because of that, proper perioperative management, meaning exactly how we handle your meds right before, during, and after surgery, is quite literally a life-saving measure to prevent a devastating relapse.
So here is our roadmap for this explainer. We'll quickly hit the buprenorphine dilemma, dive into the surgeon's perspective, look at navigating procedures, lay out the patient's action plan, and wrap up with continuity of care. Let's get into it.
Starting with Part 1, the buprenorphine dilemma. To really grasp why the medical protocols are the way they are, we've got to understand the physical science that creates this massive pharmacological headache in the first place.
See, buprenorphine is what we call a partial agonist, and it has super high receptor affinity. Picture a massive, heavy-duty truck wedged into a tiny reserved parking space in your brain's receptors. It binds so tightly and leaves so slowly that it literally blocks standard post-surgical painkillers, the full agonist opioids, from pulling into those spaces to do their job. Now, that unique feature is exactly what prevents overdoses and relapses, but man, it is also exactly what makes managing acute post-surgical pain such a tricky balancing act.
And this brings up a total game changer in modern medicine. Because buprenorphine blocked other painkillers, the old-school protocol was universally just stop the drug days before surgery, just cut it off. But we now know that doing that risks throwing the patient into a brutal withdrawal and a potentially fatal relapse. So, the new consensus from ASRA and the VA is to routinely continue your buprenorphine, or at most, reduce higher doses to under 16 milligrams a day. That leaves just enough open parking spaces for the surgical pain meds to actually work, while keeping your baseline treatment intact.
Which leads us perfectly into Section 2, the surgeon's perspective. Let's look at this whole scenario through the eyes of the surgical team and check out the decision-making matrix they use to keep you safe.
If you look at flowcharts from Beth Israel Deaconess, surgeons basically categorize procedures by how much pain they expect you to be in. If you're going in for something minor, say an endoscopy or a basic day surgery, the surgeon's move is just to continue your buprenorphine. No supplemental opioids needed, they'll just use things like acetaminophen or NSAIDs. But if they expect moderate to severe pain, like a major knee replacement, they have to pivot. For those elective cases, they might have you hold the medication for 2 days prior or drop the dose so they can use traditional opioids as a bridge through the worst of the pain.
Moving to Section 3, let's talk about navigating those actual procedures, because obviously a carefully planned elective surgery is a completely different beast compared to a sudden emergency.
If we're talking elective procedures, early collaboration is absolutely crucial. Seriously, according to the guidelines, it is never appropriate to just electively transition a patient off buprenorphine without calling their original prescriber first. It starts with catching it early at pre-admission. Then, your surgeon and your buprenorphine prescriber team up to build a tailored bridging plan. The whole goal is to make sure that even if you step down your dose, you literally never experience a gap in care that throws you into withdrawal.
Okay, but what if you're in a car accident? You need surgery right now, so there's zero time to alter your meds days in advance. Well, trauma teams have tiered protocols for exactly this. For mild emergency pain, they just continue your regular dose, business as usual. But for high emergency pain where they have to operate immediately, the team will temporarily stop the buprenorphine, hit the acute pain hard with traditional opioids, and then aggressively execute a plan to restart your buprenorphine before you're ever discharged.
All right, Section 4. Let's flip the lens entirely over to you. The patient's action plan. How do you actively advocate for yourself in all of this? These actionable guidelines from Bicycle Health and Med Central are completely empowering. First, you've got to disclose your buprenorphine use to the surgical team immediately. Don't hide it. Second, do not wait for the doctors to magically find each other. Specifically, ask your prescriber to call your surgeon. Third, bring a loved one to your pre-op meeting. Having an advocate in the room when you're stressed is a game changer. And finally, if you are just having a minor day surgery, the standard advice is to take your buprenorphine exactly as scheduled that morning.
And hey, if you're nervous that taking it means you won't get enough pain relief for a minor surgery, get this, it's wildly reassuring. Med Central points out that buprenorphine's built-in pain relief is clinically as strong as a 10 milligram Percocet. Your baseline Suboxone is already acting as a heavy-duty painkiller, which is why it makes total sense to keep you on it for day surgeries rather than swapping to something potentially weaker or less stable.
Bringing us to our final section, continuity of care. This is where we bridge the surgeon's clinical plan with your patient advocacy during that critical post-op discharge phase, the warm handoff.
The VA guidelines hit the nail on the head here. If they had to bridge you with traditional short-acting opioids while you were in the hospital bed, the absolute priority is to taper you off those before you are discharged. The medical team wants a safe, warm handoff, meaning you go home stabilized purely on your regular buprenorphine prescription. They want to keep you far away from the risks of having traditional opioids sitting in your medicine cabinet at home.
Which highlights a fundamental truth about all of this. As Alliant Quality beautifully puts it, clinical judgment is paramount. Look, these flowcharts and guidelines give us a fantastic roadmap, but every single patient is different. Your pain tolerance, your addiction history, the specific surgery you need, it's all unique to you. That's why textbook answers aren't enough, and why having deep, personalized communication with your doctors is an absolute must.
So, what if this all means for you? It means you are the central player in your healthcare. Knowing these guidelines is step one, but taking action to force your providers to connect is what ultimately guarantees you a safe, successful recovery. So I'll leave you with this to think about. How will you bridge the communication gap between your care teams before your next procedure? Get out there, speak up, and make sure your plan is locked in long before you ever see the inside of an operating room.